A lot of the signs of stroke are actually ignored by people. The one thing is that there's rarely any pain, so that's why people ignore the symptoms. It's not like a heart attack where you have chest pain and you know that you might be having a heart attack. I got to get to the hospital. So one of the important signs is that it's an abrupt onset of symptoms. So you're sitting there, you're cooking, all of a sudden you drop the spoon, your hand is weak. You know exactly when it happened. So subtle hand weakness, subtle speech changes, even numbness on one side. And one that's never really talked about is vision loss that's transient. That, oh, your vision goes out for like 30 seconds and it's back. And people are like, oh, it's nothing, I was tired, you know. That's actually could be a sign that you have carotid disease and that you're impinging on a big stroke. So even if symptoms improve, you still should get seen and not ignore them. So, and walking unsteady, spinning sensation, that's a common one. Those are just some of the common features of stroke.
One of the things many times people will present with are symptoms such as, you know, I'm having this numbness or tingling in my arm, or a few weeks back I got out of bed, or I was doing something and I felt this weakness in one of my extremities, but it very quickly spontaneously resolved. You know, so what kind of advice would you give to somebody who might be presenting to your office, or maybe even just discussing that kind of a scenario with you, you know, kind of on the sideline at the mosque, wherever they may know to meet you? What would you tell a person like that that's had kind of like a transient type of an episode where they may have had stroke-like symptoms, but they very quickly, spontaneously resolve within a very quick period of time?
So that's a common conversation I have with multiple people. If you have neurological symptoms that even resolve within a couple of minutes, you have to look at your risk factors. So as an older individual, if you have high blood pressure, diabetes, cholesterol, then you have to worry about that's your first sign that you're going to have a stroke. So when the tiny blood vessels in the brain are affected, they can actually present with these events. It's like crescendo, decrescendo. You have an event, you get better. Then you might have another event in a week, and it's getting better. So those are signs that something's about to happen. So you should get immediate medical care. You should get evaluated with imaging, with your heart, and get blood work done. You should, if that happens to you, I would recommend at least starting aspirin to try to prevent another event from happening.
So, Dr. Hafeez, I kind of want to transition to heart disease with you, because again, I'm going to kind of go back and forth between heart disease and stroke, because like I said, there's a lot of parallels. We all know that when you talk about heart disease, the first thing that comes to mind is obviously a heart attack, chest pain, all those types of things. But can you kind of break down for the audience, because I think we have a very diverse group, you know, demographically in terms of age, males, females. Does it present differently, and depending on your age, or whether you're a male or a female, anything in your medical history, like for example, if you're a diabetic, are there things that may kind of dictate the kind of symptoms that you would have if there's any concern for any impending heart attack or progression of heart disease?
Thank you for this question, and I just want to thank you, Dr. Haq, for inviting us over. I do want to just mention that I practice family medicine out in Bruce Township. So whoever knows Bruce Township, I give you thumbs up, because that's where all the farmers are. And it's where I get eggs as payment. I have gotten asparagus. What else have I gotten, Dr. Haq? Because he used to be my partner in crime, actually.
Corn.
Yes, corn. I used to get bushels of corn. So I'm out, if you know where Bruce is, it's a Van Dyke and 38 Mile. So it's very, very far. And I also practice obesity medicine. And why is that important? Well, it's important because some of the comorbidities that come from obesity is what? Heart attacks and strokes, right? So obesity is my passion, right? I want to help patients get better. And how do I make them better, right? And that's with lifestyle changes, right? So I just kind of wanted to mention that. Now, give me a raise of hands who here knows someone or may personally even have experienced a heart attack or stroke. I know I have, right? I'm sure all of us have either known somebody or even personally have experienced a heart attack and stroke, right? So this really hits home very, very close. And with our population as well, unfortunately, those rates are higher. Is that correct, Dr. Malik? Yeah. So in particular, when we're talking about heart attacks, the classic symptoms of a heart attack is what you see on TV, right? What do we see on TV? Somebody throw out a few examples. Chest pain, right? How does that chest pain present? It's crushing chest pain, right? So you'll see that man that's hunched over, right? They're having crushing chest pain. How do they look? Do they look relaxed or do they look distressed? Can't hear you. They're sweaty. They look distressed, right? They're having shortness of breath. They look very uncomfortable. They may collapse. They may become unconscious, right? So that's the classic symptoms, what we see on TV. But realize that that's not how everyone presents when it comes to a heart attack. And that's why in a certain subset of the population, particularly our wonderful women, we present differently. And because of that, sometimes it's not diagnosed quickly enough, and therefore it can lead to early demise, right? Because we don't recognize it. So for women in our lives, right, it can present as atypical symptoms. And those symptoms may be, I don't feel good. I just feel so fatigued. Honey, I'm having abdominal pain. I'm having dizziness, right? Those are atypical symptoms that may mean, or it may not, but it could mean that there's something more going on. And that's why it's scary for women, and that's why it's scary knowing that women can go undiagnosed and therefore have early demise because of that. The age that we are worried about, because Dr. Haq mentioned age, is if you're having a heart attack beyond earlier than age of 50, that's obviously a pretty red flag sign, because there's probably a strong family history, correct? That there is a heart attack, a heart attack propensity in the family. But the typical person, is probably in their 60s, and they have certain characteristics. And what are those characteristics? Can someone throw out a few characteristics in a typical patient that you may think of that would have a heart attack? What do they look like? They're obese. Exactly, right? You see they have a gut. I'm just going to be frank, right? That's up to here. Right? What does that mean? That means that there's fat around their organs, right? What else? Yeah, so when they're walking, they're huffing and puffing, right? So with stress, their heart is in stress. When you're walking, when you're running, you are stressing the heart. And guess what? That can lead to, a heart attack. What else? What other habits may show up? Smoking, yeah, and I'm going to talk about that later. But smoking, right? Other lifestyle, aspects is just sedentary, right? So I'm not going to get into all of that, but I just kind of wanted to mention that there's certain characteristics that we're looking for, but realize that women are a different breed and we do present differently, which is scary, right? Because it may go undiagnosed. Sorry to hijack that, Dr. Haq. Bye.
No, do you want to add anything to that, Doc, in terms of from a stroke perspective? I'm going to kind of dive in now because you kind of highlighted some of the risk factors, in terms of hypertension, diabetes, obesity. Was it fair to say then, Dr. Malik, that the risk factors for a stroke or a TIE, even for that matter, are very similar to that, or is there anything else that you want to add to that in terms of risk factors and things that make you more prone?
Those are the main risk factors, and obviously elevated cholesterol. But in the Indo-Pakistani epidemiological studies, the most common cause is actually diabetes. And then, I've done talks in Pakistan, and I've looked at the causes of stroke, which is very prevalent in young people in Pakistan, is hypertension. Because those are two things that go undiagnosed. They're, as you know, the silent killers. So you don't really have symptoms unless they're extremely elevated. So you might be a hypertensive patient for years and not know it. And so you've made the damage to the blood vessels, whether it's the heart or the brain. Those are the two major risk factors, especially for the people in our community, is hypertension and diabetes. And as Dr. Nasir Ahmad always says, diabetes is the disease of food, right? So our diet is very is a big problem for us to have heart attacks and strokes, and so that's something that has to be addressed even at our monthly dinners. So,
sure. So, using that as a prelude to something I want to actually dive into, because I know Dr. Hafeez, you mentioned that obesity is something you're very passionate about, and I know that directly ties into what Dr. Malik was saying in terms of diet. What kind of advice would you give to the audience? I mean, we all know what kind of foods we like to eat.
Right.
But, the issue is always, when you have these conversations behind closed door with patients is, I want to enjoy life. I can't stop this completely. I can't go cold turkey from eating rice. These are very impractical kinds of advice that may come back and turn around and tell you. Yeah. So what kind of practical advice would you have for people of our demographic in terms of what can we do, especially for people that haven't developed any heart disease yet, people in their 30s and 40s, and of course even people that have established heart disease? What kind of advice would you give to both of those sets of individuals in terms of what you can do, without making too much compromise in terms of enjoying life and at the same time being healthy? And if you have established heart disease or if you had a stroke, what are some of the red flags that you really have to be vigilant about and not really stay away from?
Yeah, that's a loaded question. So I guess, kind of going back to that concept of everything in moderation does come to mind. We should eat carbs, but we should not eat the plate full of biryani, every few days, right? So it's that concept of eating everything but in moderation. So at the obesity clinic, we really focus on, a certain type of diet plan. It's more so of a high protein diet plan, which may not be good for everybody, especially if you have like kidney disease, for example. But we really focus on a concept where we're eating protein, vegetables, and then carbohydrate, right? So when we're telling patients, take your plate, divide it into thirds, okay? But not equally. The largest portion would be protein, right? So lean meats like chicken, you could even do like turkey, even goat is actually pretty healthy. The meats that tend to be pretty fatty are the beef, and then of course the lamb, right? And then next should be your vegetables, right? Those are healthy carbs. Why? They have vitamins, they have fiber, which helps you break down. So you want to focus on that next. And then after, you have your carb, right? So when you're eating, you have to follow the 3 to 2 to 1 rule. What does that mean? 3 bites of your protein to 2 bites of your vegetable to 1 bite of your carb. But in our culture, we do the opposite. We have a whole plate full of rice, and then we have a little bit of vegetable on the side, and then we have our meat scattered in, right? And so you really have to see, what's my proportion of the food that I'm eating, right? And you should be eating carbs, but not a plate full, right? So really the whole concept of moderation, and that's an Islamic concept, correct, Dr. Haq?
So if I'm in my, say, 40s or 50s, and I take blood pressure medication, maybe some Lipitor for high cholesterol, BMI is a little bit elevated, and I'm just asking you, so what should I eat? So you think following that thirds rule is sufficient?
It's one step, of course there's, many different diet plans that you can do, but the whole concept is, what's the effect, right? And majority of the diabetes that you're referring to, that Dr. Malik is referred to, presents because we have too many carbs. And if I just take a moment and just talk about the pathophysiology of what carbohydrates do, it will make sense, right? This whole concept that I'm trying to convey will make sense. So what happens is when we have our plate full of rice, right, we have an influx of glucose that is now flooded our bloodstream, okay? And we have and then we have our cells, right? And what the cells should do is take the glucose, and it should take it inside the cells via a hormone called insulin, and use that glucose by taking it into the cell and breaking it down. But what happens when we influx our system with too much carbohydrates, that process gets altered, okay? Meaning that the sugar that's hanging out in your bloodstream gets exposed to the insulin, and the insulin is like, there is just way too much glucose hanging around in my bloodstream. I cannot handle this, right? And that is the essence of a concept called insulin resistance, right? So now that glucose is not going into the cell to be utilized as energy. It's now hanging out where? In the bloodstream. And what does that cause? How I tell patients very simply is that sugar is sticky. Just simple terms, nothing fancy, nothing medical, right? Sugar is sticky. What does it do? It sticks to the arteries. And then what sticks to the arterial wall is plaque, right? So next comes that fatty lamb that you just ate, right? That has cholesterol particles, and that starts sticking to the wall. Now give it 10, 20, 30 years, and now you have a blockage, right? So if you kind of understand that basic principle, a lot of what's causing these issues, like diabetes, for example, is due to eating a high carb diet.
Sure, yeah, absolutely. So transitioning back a little bit now to stroke, Dr. Malik, I think that one of the things I want to highlight to the audience is a lot of us have elderly loved ones that we care for, and sometimes it's hard to identify when somebody is actually having a stroke. And I know we love to use mnemonics in healthcare. So can you maybe elaborate? We use FAST, obviously. So maybe explain to the audience a little bit about like what's a 911 situation for a family member that might be having a stroke.
So FAST is what we use in it. You look at if somebody has F is for face, so facial asymmetry. So you have them smile, and one side's a little crooked. A is for like aphasia, so when you're talking to your family member, they're just not making sense. It's not necessarily that sometimes they're talking gibberish. Sometimes it's slurred. Sometimes they're just really struggling to find the word that they have to say. And then you have to know if one side. So what I usually tell people to do is put your hands up if they drift down. That's a weakness. So if they're not speaking well, anytime time is of essence, because you should just, if they have any of those symptoms, call 911. And I always tell my patients, it's not your job to know whether it's a stroke. It's your job to know whether it could be a stroke. Okay? Because we do have a medication that we could give if you present within 3 hours. And I use TPA, and now we actually have a new one called TNK. So if you go to some hospitals, they may be using TNK. And so the time is brain, just like time is heart, right? So the longer you wait, the larger the damage. So those are the things that you should, it's not even, it's actually harder to think that is happening in young folks. Mm-hmm. The elderly, you might say, oh no, there is something, this is not my dad, my dad's not acting right. I mean, my dad was dizzy. I said, oh, I'm the doctor, I think the worst. I said, you're dizzy, let's go. And dizzy was nothing, but I said, let's go, right? But young folks, you're just like, oh, it can't be anything. You don't have any risk factors. You're, 20 years old. But don't think that your kids are not at risk. of stroke. We're seeing more and more 20, 30-year-olds having strokes. And that's another conversation I can have. But
Again, then that ties into heart disease also, Dr. Hafeez. Younger and younger people are unfortunately also having heart attacks. And a lot of the heart attacks the younger people are having are unfortunately very easily preventable with lifestyle and social modifications. So can you just maybe highlight some of the risks of things such as smoking? And in our community, we don't have to worry so much about alcohol, but it's definitely something that should be mentioned medically. And also, now, one of the biggest challenges that we haven't really identified now, but unfortunately, I think we will in the years and decades to come, are some of the ramifications of vaping.
Yeah.
So now you have more and more children vaping, unfortunately. And so can you speak to what is it about smoking that increases the risks of heart attacks and strokes?
Yeah, okay, great question. So when you talk about smoking in particular, nicotine does a few things to the heart. Okay, so one, even though we think that nicotine relaxes us, it actually does the opposite in the body. It actually stresses the body. It causes the blood vessels to constrict, right? So now you have less blood flow. So if you think of like a hose, right? Now the hose is kinked, for example, it's narrowed. And so now you have less blood flow. It also thickens the blood, okay? And then in addition to all of that, nicotine causes inflammation in the body, right? And a lot of these processes that we are talking about, diabetes, heart disease, strokes, they're all inflammatory. When we check for inflammatory markers, they're actually elevated in this patient population. So knowing that we are doing a substance like a vaping, right? Even though there's some vapes that have nicotine, I understand, some vapes that don't, regardless, right? These chemicals that we're putting into our body are going to cause inflammation. And that's going to cause potentially a heart attacks and stroke. You talked about some of the risk factors, and I'll kind of briefly mention that. I just in my head, I kind of bucket them into two little buckets. So one is modifiable risk factors, and one is non-modifiable risk factors. So throw out some answers here. What are some non-modifiable risk factors? Gender, right? You can't change if you're male or female, but we know that males tend to have more risk of heart attacks and strokes. What else? Genetics, exactly. You cannot change your family history, right? So if you have a strong family history, especially of someone having a heart attack before the age of 50, that's something that you need to watch out for, especially if it's a first-degree relative, so either a parent, a sibling, or even a child, especially if it's before 50. So those are some of the common non-modifiable risk factors. Now, what are the modifiable risk factors? What can we change in our life? Obesity. Yeah, so let's get up and move. Let's exercise. The recommendation is at least 150 minutes of exercise, of moderate intensity exercise per week, which comes out to be what? 30 minutes a day, 5 days out of the week. You can go on a brisk walk, right? As long as you try to elevate your heart, you sweat a little bit, that's a moderate intensity exercise. That's pretty reasonable to do. What else? Yeah, so smoking versus not smoking, you have a choice, right? That's something that you can modify. We talked about diet already, right? Alcohol, like Dr. Haq mentioned. The other thing that I just kind of wanted to briefly mention as well is to see your doctor regularly. I've noticed that in our community, there's just this general mistrust of physicians. I don't know if it's something that maybe comes from back home, where maybe, not everybody, but maybe some of the physicians may have like a kickback system or get money for referrals or medicines. But I can tell you, we took the Hippocratic Oath, right, to do no harm. And so when we're seeing patients, I'm doing what's best for you based on the guidelines and based on evidence-based medicine. So I don't get any kickbacks from giving you advice on how to treat, a certain condition, or even recommending certain medications. And so going back to one of those modifiable risk factors is see your doctor regularly. So when you go in for your appointment, you better leave that office with another appointment. You would be surprised. Working out there in Bruce, I am so amazed. I have patients that see me regularly. If they're diabetic, they're seeing me every 3 months. If they're, chronic conditions, I'm seeing them every 6 months. If they're young and healthy, I'm seeing them 1 year. But I've seen these patients over 10 years now, and they come in every 6 months on the dot. But that's how they stay healthy. That's how we catch things. If you only go to the doctor when you're sick, you are doing it all wrong. You should go to the doctor when you're healthy. Why? That's how we keep you healthy. Make sense? That is the essence of preventative medicine. Back home, they don't practice preventative medicine as much as we do here, right? Everything is reactionary. Oh, I'm sorry, you've been diagnosed with breast cancer. There's nothing we can do about it. Over here, we say, you should be getting your yearly mammograms. Right? Why? Because I can detect a cancer early on so that we can treat it. Okay, so that's the idea. We're here to practice prevention, right? That means conversation about diet, exercise. When you see your doctor, I'm looking at your vitals, your BMI, which is your body mass index. We're looking at lab work, right? We're looking at waist circumference in the obesity clinic, for example. So we're looking at all of these things to see if they're normal, to see if they're abnormal, and then give you appropriate advice. Go see your doctor and see them regularly. If not, you're not doing it right.
Right. Well, thank you. That's great advice. I'm going to come back to that in just a moment, but I want to transition to something important related to stroke. Dr. Malik, I know we talked about a lot of the different risk factors and some of the symptoms and how strokes manifest. One of the questions that frequently, I even get, and I'm sure you hear this way more often than I do, is, questions when it comes to the kind of medications we put people on, after they've had a stroke, after they've had a workup done. And one of the questions I get from time to time is, why are you putting me on a blood thinner when I had a stroke? Doesn't that mean I'm more likely to have a stroke? So can you maybe just kind of explain to the audience how there are different types of strokes, whether it's hemorrhagic stroke or ischemic stroke, and how irregular heartbeats increase your risk factors of having a stroke, and how important it is to what Dr. Hafeez just said, to see your primary care doctor regularly so he can identify these types of things that put you at a high risk for stroke?
So that's a good question. I get that question all the time too when they come back to see me after they've been in the hospital. So there's two different types of strokes. 20% are hemorrhagic strokes. That's when you bleed into the brain. The most common cause of hemorrhagic stroke is blood pressure being uncontrolled. Other causes are aneurysm ruptures and other blood vessel abnormalities where that can cause hemorrhages. So those patients they're not put on aspirin or Plavix or any kind of blood thinner after those strokes. So the majority of the strokes are ischemic strokes. So of ischemic strokes, actually, the number one cause is blockage of the large arteries. So atherosclerosis, the same reason why you get cardiovascular disease and heart attacks. In order to, so the blood vessels, as Dr. Hafeez says, over time they slowly get narrowed because of uncontrolled hypertension. It slowly hardens the artery, then cholesterol builds up, and then diabetes can accelerate it. And then in order to prevent the blood from clotting, because it's more, you can think of it as a drain. I use the analogy of a drain. It's getting clogged by hair, right? So the water is flowing really slowly. We have to open up the drain in order for the water to go down. In order to prevent more, so the blood is having a harder time going through the artery, so we have to get it thin so that it can flow. So that's why you're being put on an antiplatelet. Actually, that's the number one secondary stroke prevention medicine. It can reduce your chances of having another stroke by 25%. And there's no other medicine that can be given that can reduce your chance of another stroke as much. Now, the question then comes up, there's different blood thinners, aspirin and Plavix, and then now we have Eliquis, so those anticoagulants. 25% of strokes happen because of atrial fibrillation or an irregular heart rate. Women over the age of 70 have a higher chance of having atrial fibrillation. And sometimes you don't even know because you're not necessarily feeling the palpitations, you're not feeling your heart racing. The only way we really detect it is, they've had the stroke and how it looks like on imaging and how you present, and then we do cardiac monitoring, and then we find that you have the irregular heart rate. So that those patients are better treated with anticoagulants such as Eliquis and Xarelto, and warfarin is the most common. So those are the medications that we can use. Can I go back to something we talked about? So I want to just touch base about stroke in the young, okay? I have all senior citizens here, so almost, right? But stroke is common in the young folks, okay? Dr. Haq mentioned we don't have to worry about alcohol in this community. So I actually differ with that impression because I see patients from not necessarily our community, but from the Muslim community in general. And shocking to me, it is common. Alcohol increases your risk of hemorrhagic strokes, not ischemic strokes. But things that are very problematic are hookah bars. So my son is really young, so he doesn't do these things, but I hear that kids go almost every weekend to the hookah bars. So smoking the hookah is worse than smoking cigarettes. So you can go to the hookah bar once a week, and it's as if you're smoking about 2 to 3 packs of cigarettes that week. Okay, so that's something to be careful. When your kids are saying they're going and hanging out in Dearborn, figure out where they're going. The other thing is college kids, high school kids drink a lot of energy drinks to stay up, to study. Now that's becoming more common cause of stroke in the young folks because it has the effect of cocaine. It constricts or narrows your blood vessels. So if they're drinking a lot of them, especially during exam time, you're constricting your blood vessels, and it's constricted for a long period that they can have a stroke. The other thing is Adderall. I guess Adderall is a big thing in college. College kids are taking Adderall to stay up for exams. So these are all things that we have to think about. We think, our kid doesn't have cholesterol, they don't have blood pressure, they're okay. But the lifestyle choices they are making can cause them to have their ischemic strokes. So.
Yeah, absolutely.
Yeah. It does increase your risk of hemorrhage. That is true than if you don't. So that's why you have to be careful, about falls and things like that. And so that's also another reason why I tell patients, they said, if you think it's from my heart, but you haven't seen that I have AFib, why don't you just start me on the blood thinner? And I say, because there's an increased risk of hemorrhage. So unless I have a reason to put it, but then you go to risk versus benefit. So not being on it is a higher chance of having an ischemic stroke than being on it and having a little hemorrhage. So,
in your practice, do you see a lot of patients?
Not that common, no. No, only when they have trauma. They've fallen and they've hit their head but just not spontaneously. But I mean, it's even more important in those patients to make sure that their blood pressure is well controlled, because the reason why they would hemorrhage is because they have consistently elevated blood pressure.
What would you say, Dr. Hafeez, to a patient that may present to you, and kind of piggybacking on, the comment the audience member made about, can I take something prophylactically, basically? What about, like, if someone were to say, if I take a baby aspirin every day, would that lower my risk of developing heart disease when they have not developed any heart disease. Is that something you recommend to your patients to just take a baby aspirin? Because I know this conversation has come up a lot because of the recent revision of the guidelines.
Yeah, that's a great question. I feel like the aspirin debate for cardiac reasons goes back and forth. Some say, you should always do it, and others say, that we should not, based on the risk of bleeding. So obviously, we don't use aspirin to prevent the development of coronary artery disease, right? If that's going to happen, that's going to happen. What aspirin would do would be to thin the blood so that if you already have coronary artery disease, then the blood can go through the constriction easier. So how we determine if a patient should go on aspirin, because there are risks to aspirin as well, right? Like Dr. Malik mentioned, there's a risk of bleeding. So we don't necessarily want to put every patient on aspirin, but we calculate what their risk is of heart attacks and strokes, and that comes from a calculator that we use that was developed by the American Heart Association to determine what is the risk versus benefit ratio, and if they're considered high risk for heart attack and stroke, and what determines those factors: age, what their cholesterol is, how good or bad your blood pressure is. And so once we put all of those, parameters, and then also what other chronic conditions they have, like diabetes, for example. Once we put all of the information in our handy dandy calculator, we're able to, calculate what their risk is of heart attack and stroke, and then make an informed decision with the patient if they should go on aspirin or not. And typically, if we do put a patient on aspirin, it's typically a baby aspirin, 81 milligrams. The studies show that high-dose aspirin doesn't really, make much difference when you compare it to the 81 milligrams, and in fact, there's more side effects of bleeding risk. So we tend to just stick with 81 milligrams. So it really is a case-by-case basis, and you have to base that on the individual patient.
Sure. And do you think family history, is that something that dictates if someone were to say, my father or mother had a heart attack at a very young, so that would dictate that?
Absolutely, yeah. If father had a heart attack under the age of 50, then that factors into the equation.
Sure. Transitioning now a little bit into, the fact that, from a conversation from a stroke perspective, there's a social aspect to stroke and heart disease as well. And what I mean by that is, when you have an elderly patient that suffers a stroke, it poses a lot of social challenges: caring for the patient, providing the right kind of care, home health care services, skilled rehab. There's a lot of things that come up, and you mentioned, in our community, there's certain types of reservations. It is what it is, and hesitations and admitting our elderly loved ones to facilities like nursing homes, skilled rehab, that type of thing. So when you have, Dr. Malik, a patient that suffers a paraplegic or hemiplegic stroke, and that it is going to be next to impossible for the loved ones at home to care. Well, a lot of times the children will say, well, I'll take care of mom, I'll take care of dad, etc. And that there's going to be challenges that they have not even been able to, it's hard to foresee some of these challenges. So what are some of the options that you would advocate for and reassure community members that it's okay, to take some of these options up when you have a loved one, an elderly loved one, that may have suffered a stroke that requires further attention?
Well, that's a very good question, and actually it's a question not for stroke, but for a lot of our medical issues. So a lot of my practice of medicine goes by personal experience. So as many know, my mother had health issues. We had to take care of her. That's our experience with the healthcare system, what the rehab facilities are like. That's how I learned as a physician what the healthcare facilities are like and things like that. So I do a lot of personal experience counseling. But we try to explain to them, it's difficult with elderly, especially if they have pre-existing like dementia or other cognitive impairment because they wouldn't participate in inpatient rehab as much. So there's the two types of places. Inpatient rehab is where you go for like 1 to 2 weeks. It's aggressive rehab, 3 hours a day, and that's actually the best you can get. And I would always advocate to send somebody to an inpatient rehab facility if it is possible. So the way it works in the stroke units or in the hospitals is that our therapists assess the patients and they determine if they would qualify for inpatient rehab or would they need more of a skilled nursing facility. The skilled nurses facility, you get 1 hour or maybe 3 hours in a week. It's a very low-key rehab. However, taking people home is very difficult. It's very difficult. The resources are not there, and it's very expensive. Insurance companies don't pay for the stuff. If you have Medicaid, you can get some help through the state, but it's minimal. So I try to at least encourage families to try the facilities. Because they're getting some rehab. And then when they get home, we try our best to make sure that we can try to get a nurse to come home. But then I said family has to be proactive. So they have to do some exercises with the patient, and they can't just leave it to somebody else for 1 hour in a week. They're not going to get better. So, I mean, it's very difficult. We have a lot of reservations. They're like, how can we send our mother to the nursing home? She took care of us. How can we? But the family has to look at what resources they have. So it has to be then multiple people in the family taking turns because it is very difficult to do at home.
Yeah, very challenging. And there's other benefits too. I think, speech therapy and those types of things. A lot of people may develop dysphagia. Diet also becomes a major issue. All those things I think would also be of great benefit with further assistance rather than trying to figure out all these things at home, I would say.
Yeah, and like the hospitals try to give all of that education to the families before discharging them. But we do have a lot of reservations, especially within our Bengali community in Hamtramck. They don't really like to send their family members to rehab, but we really do have to convince them. So,
tying it all together here, Dr. Hafeez, there may be many people in the audience, thinking to themselves, maybe I need to get a stress test, or maybe I need to do something more. So obviously, like you mentioned, visiting with your primary care physician is a good place to start. How would what kind of other advice would you give, in terms of, getting yourself evaluated with primary care? Who would be a good candidate for a stress test? Some people may come and ask you there's these new tests now, where you can do a CT scan of your coronaries and get your calcium scores done. Which ones do you advocate for, or is it more on a case-by-case?
So it really is a case-by-case basis. As I said before, when you go in to see your primary care physician, they are looking at you. They're looking at your vitals. They're looking at your weight. They're ordering blood work. That is the best test to screen for heart disease, right? What's your cholesterol? Are you diabetic? What's your A1C? So getting those parameters is a good start. We don't necessarily order an EKG on every patient. So the guidelines say that we should not order an EKG for screening. We only order an EKG, which is basically an electrocardiogram of the heart, only if you're having symptoms. So if you come in with maybe shortness of breath or chest pain or fatigue, that's a reason for me to say, okay, we need to order a EKG to further investigate. Now, let's say that I get that EKG in the office and it just doesn't look right. There's some abnormal waves. It's not a normal EKG. And you're still having symptoms, at that next step, that would prompt me to possibly order a stress test. Now, in patients that are lower risk for coronary artery disease, but they have other risk factors, let's say a strong family history. There are some newer tests out there. There's like a coronary CT scan you may have heard. It's just a CAT scan that checks the amount of calcium that's in your arteries, and it gives you a calcium score. We tend to use that in patients that are lower risk for coronary artery disease, and even Henry Ford has like a $99 like cash pay. But if I'm suspecting that this is a patient that is high risk, right? So obesity, smoker, over 65, diabetes, I'm ordering a stress test, and we're aggressively working this patient up.
Great. So it ties into what you've been kind of harping on all night. Is just if you visit with your doctor, I think a lot of those things, regular checkups, I think are the theme of the evening. I want to just highlight one more thing regarding stroke before we open up the floor to questions to Dr. Malik. You know, a lot of patients and actually family members will bring in stroke survivors and give a presentation that, you know, mom or dad just aren't the same anymore. They seem to be very flat. You know, they're not very engaging anymore, even though they're kind of on the road to recovery, if you will. Can you just speak to a little bit about the prevalence and the expectation of maybe things like depression that may settle into not only stroke survivors, but even heart attack survivors? Is that something that we can expect? And what would you tell the audience if they do have family members that have suffered from these things to kind of be vigilant of and look out for?
So there are three things that are actually now becoming more, we're focusing more on. There's one is post-stroke fatigue. Mm-hmm. You know, they say, you know, my mom is always tired. She's always just like, she just wants to sleep. And so that impinges on the ability to do therapy. The therapist coming, I don't want to do it. No, send them away. Right? So, you know, Dr. Humayun is one of our PM&R doctors for stroke. So for fatigue or for people who are not, that's very common and it's not really recognized or addressed a lot. We use amantadine or something to try to keep them awake so that they can participate in their rehab, because if you postpone rehab, the recovery is a lot harder. Depression is very common in anything. I mean, depression is common everywhere. We got two psychiatrists sitting in our, on this side of the room. I don't know anybody on that side, two on this side. So depression is very common. I actually tend to start antidepressants in the hospital because they may not recognize it at first. So family members like, oh no, it's, you know, oh, he's just tired. But it's an extremely common. I would recommend trying to engage your family members in activities that they like to do. If they're elderly, they all love their grandchildren. So bring your grandchildren over, you know, that's gonna get them happy. But I do start an antidepressant almost on majority of my stroke patients. And one of the things that's not even recognized from a lot of neurologists is cognitive impairment after stroke. You know, the people can talk, they're moving, they're engaging in everything, but they're just not right. Like, you know, we have to tell them a couple times to do this. So now there is cognitive therapy, and that has shown to be very, very good in improving on patients who are not engaged in activities. So, and that's done through speech therapy. So if you have family members who have that, I would encourage to get that referral, because they do cognitive activities. You can do brain games, you can do puzzles, you can do things to try to improve that. So those are three things that are not even recognized by all neurologists. They're just starting to becoming recognized. And so it's very vigilant, and honestly, I go by what the family tells me. You know, I don't say, oh no, they look fine to me. I said, no, it's your family member, you're saying this is happening, we'll treat it.
Sure.
So can I just mention something about not only going to your primary care, but taking your medicines? Compliance. The number one reason in Indo-Pakistanis of having recurrent strokes is that they stop their medicines because they're feeling better. Okay? Their blood pressure is good, oh, I stopped the medicine. Yeah. So compliance to you're feeling better because you're taking medicine. So we have tons of patients come back because, oh no, I was doing okay, doctor, I just stopped it. So make sure you don't stop any medicines without talking to your doctors.
You know, I'll give you a practical example of something you just mentioned. I had a patient who just recently had a stroke, and that was their second stroke. And when they followed up with us, we asked them, "Are you taking your Eliquis?" And he said, "No, my dentist told me to stop it." And there's some truth to that. Now, the dentist probably said to stop that medication for a few days because they were doing a dental extraction. And so they stopped and unfortunately, you have a stroke. So can you maybe highlight, what do you tell your patients, Dr. Hafeez, that are going for minor surgical procedures, that are taking antiplatelet therapy? Do you have a formula that you use? What kind of advice do you give to people that are being told by specialists, dentists, etc., to maybe stop some of these antiplatelet therapy? Fundamentally, they should be checking with the primary, but unfortunately, as we all know, it doesn't always happen that way. So what kind of advice would you give to people outside of just, touching base with you?
Yeah, so I mean, obviously if you're on a blood thinner for a chronic condition, it's probably for a chronic reason, and therefore you chronically need to be on that medication. In the case of blood thinners, as Dr. Haq said, you're going through a procedure. It probably means that the dentist wants you to temporarily stop the medication, and then it should be restarted. And then, of course, depending on what type of medication you're on, that determines how long the break will be from the medication. So I don't know if that really answers your question.
I think that's a fair assessment. I'd like to open it up now from the audience perspective. Does anybody, if anyone has any questions, please, feel free to raise your hands and we can give you an opportunity to ask any questions. Yeah, go ahead, ma'am.
My question is from Dr. Hafeez. Do you recommend to your patient who they are above 50s, do they have, otherwise they have normal blood pressure and slightly weak, do you recommend treatment with aspirin?
So like I said before, it's a case-by-case basis. I would calculate their risk of heart attacks and strokes based on a validated assessment recommended by the American Heart Association. And then based on that assessment, I would determine if a patient would need. So it's really not a blanket, one statement fits all. We have to calculate it based on your individual profile, what your pressures are, what your chronic conditions are. I mean, if a patient has already had a cardiac event, then yeah, you probably should be on an aspirin. But when we're talking about prevention, that all depends on your profile. So keep your profiles clean, keep your blood pressure down, keep your weight down, keep your cholesterol in check. Then we won't have to start these medications. Great question.
Yeah. Any other questions? You go ahead. Right here. Okay.
I think in our community and culture, if you are in a group of people, 10, 15 people are sitting, and you mention a medical condition, you have about 15 treatment options given to you by people who have no knowledge of medicine. So I think it's very, very critical to avoid that stuff. We are used to a lot of herbal medication. There are a lot of folks out there who promote those ideas. They may be beneficial, but not necessarily proven.
Yes.
And so always talk to your doctor before switching your medications and going on the limb of these doctors or special treatment people who have the magic answer to your problems. They cure diabetes, they cure high blood pressure, which isn't true. These are the chronic conditions. You have to take your medications. If you have high blood pressure and you don't take your medicines, the pressure is not going to be controlled.
Mm-hmm.
If you have diabetes, unless you can cut your weight and starve yourself, you still need your medications. you have seizures, you need your medication.
Yes.
Mm-hmm.
So they are good to prevent things happening, but they are not necessarily curative. So the medicine we have at the present time is basically preventive in nature.
Mm-hmm.
And it's difficult to be on medications every day. People get sick and tired, and more medicines are becoming costly. I think we as physicians have a tendency to go with new medications, and that turns out to be a big bill for the patients, and they cannot quite tolerate it, particularly elderly. So talk to your physician. Say, what other alternative is there? There may be quite a few medications that have been used for many years and are very effective. They don't have to be fancy. In regards to the blood thinners, they don't, by themselves, don't increase the bleeding, don't have necessarily high bleeding, unless your blood is too thin. So if you are on Coumadin, please get your INR checked regularly, because it can go up and down with your diet, and if the INR goes up, it could bleed from your urine, stomach, and so forth. But if you get any injury, your risk of heavy bleeding is much higher because the blood does not clot. So avoid injuries, cuts, and so forth. That would be just kind of a general sense.
I just want to make a comment about the blood thinners. So this is my take. It's different than family practice maybe, or is falls is not a cause of not being on blood thinners. Okay. A lot of family doctors say no, increased risk of falls, do not start blood thinners. In my personal, it's not a reason to not start blood thinners for somebody who has atrial fibrillation and who's had strokes. Because the risk of having a major stroke with atrial fibrillation is so high that if they had another one, they're going to be bedridden. So you'd rather prevent that life change and just be more cautious about when they're walking and make sure they walk with a walker and things like that. So.
You know, to follow up on what Dr. Malik was mentioning, a lot of times patients will bring in a bag full of herbal medications and vitamins and all kinds of things. And, you know, they may or may not be FDA approved. I try to lean on the shoulders of the FDA when I try to explain to people you may not need all these things. So what kind of conversations do you have with patients like the ones that Dr. Malik is referring to?
Yeah, that's a great question. I usually say that Americans have the most expensive urine, right? Because they're taking all these unnecessary supplements. Your body doesn't need it. And what does it do? It dumps it in your urine and you pee it out, right? So a lot of patients do ask these questions. What do you think about ashwagandha and all these different? You know, my vocabulary has increased significantly with all these with all these words I've never heard of. And what I say is basically what Dr. Malik says is that we as physicians practice evidence-based medicine, and what that means is that it's based on research. It's based on randomized controlled trials, right? And unfortunately, we haven't done randomized controlled trials on a lot of supplements. That doesn't mean that there isn't value to it. I mean, there could be some supplements out there that are valuable, but there's no evidence behind it. And I don't know what the risks are, the benefits, and if there's any side effects to them. So you just have to take everything with a grain of salt. Just be careful. Again, there can be a lot of medication to medication interactions with supplements, so you just have to be very careful.
Sure. Did you want to add something?
Yeah, actually, in my recertification, I had to read articles, and there's articles about vitamin supplementation and stroke, and there is not an increased benefit of taking vitamin supplementation, you actually get more benefit from eating the foods that are high in those vitamins. So the actual pills are not beneficial. We have done studies with vitamin supplementation, stroke prevention, and all of them have been negative. So, and on the caveat, not stroke, but other neurological issues, you can actually get neurological problems with too much of the supplements. So we have, people coming in with their legs numb, they can't walk. It's because they're taking too much of these extra supplements. And so toxicity is also a problem.
Oh, sure, yeah. I think we had one more question. Yeah, go ahead.
Sam.
Two questions. One is, what is the role of stress in both the conditions? And secondly, in the past, the treatment for diabetes was starting oral medication and then insulin. But now we have new medications. Where does that fit, insulin or go to the new medication?
Can you talk about the new one?
Yeah. When it comes to diabetes, the oral medications are still a great option. The number one medication you may have heard of is metformin. It's been around for a long time. It has a pretty strong safety profile. Insulin is still a great medication. It's effective. It helps lower the A1C. It's safe. Yes, it's an injection, but that's, a pretty minor concern. Now, there's a whole class of other medications that just came out, actually multiple classes. And I don't want to be too technical, but, one of the major classes are a whole class of meds called GLPs. You may have seen the commercials for it. There's Ozempic, there's Trulicity, there's a new one out there, Mounjaro, which is wonderful for weight loss, even though it's not FDA approved for weight loss. And then there's other classes of medications that are oral and injectable, like the ones I just mentioned are all injectable. They're wonderful as well. So it's really a case-by-case basis. I'm looking at what the patient's A1C is, which is their marker of diabetes, how bad their diabetes is. I'm looking at how compliant the patient is. Can they inject themselves 3 times a day with insulin? If that's not the case, I can put them on, let's say, Ozempic. It's a once-a-week injection, and guess what? Now they're compliant. So there are benefits to those newer medications. A lot of them result in weight loss. So at the obesity clinic, I'm using a lot of those medications. Some of them are off-label use, so they're not FDA approved for obesity, but I'm still using it for obesity. But then there's other meds which are FDA approved for obesity that can also help lower the A1C. So they have benefit as well. Again, you have to talk to your doctor and figure out what's best. The other barrier we have is insurance coverage. There's always some type of insulin that your insurance will cover, but with these newer medications, they're expensive. A vial of Ozempic is over $1,000 a month. Most patients can't afford that, and most insurances don't want to pay that. So then that goes back to, then you have to go on insulin. So again, don't discredit the newer medications. They're highly effective, and the studies have been very, very promising.
The second part, we got to speak to the stress he mentioned.
Yeah, I was going to say that. In regards to stress being a risk factor, that is actually a risk factor because stress increases the other risk factors. So with stress, your blood pressure goes up. With stress, your sugar levels go up. So, the risk factors for stroke and heart attack are becoming uncontrolled because of stress. Unfortunately, no one in the world doesn't have stress in their life, right? Stress is everywhere. It's a matter of finding a healthy way of dealing with that stress. The easiest way is having the time do some exercise to try to relax. Also, one of the things for stroke risk factors I didn't bring up and I just remembered is sleep apnea. It's always overlooked. But sleep apnea you don't have to be obese You can be thin and still have sleep apnea. So that's something to always be evaluated for if you're constantly tired during the day, falling asleep, because treatment of sleep apnea with CPAP will actually help control your blood pressure, can also help regulate your sugar levels even better too. So it's actually, it will help with all the different risk factors for cardiovascular and stroke disease.
Yeah, go ahead.
How often do you see stimulant-induced cardiac or neurological events in your practice?
That's a good question.
In stroke, it's rare. I mean, I probably see a case a month, okay? But it's there. So we always have to be cognizant of it. Obviously, it's what we investigate in stroke in the young. Because even other things like Imitrex can cause it too, Sudafed. So these are all things that we have to ask when we have somebody who has no other risk factors for cardiovascular and stroke disease. What else are they taking? Even
So, do you want to go ahead and finish your train of thought, or are we all wrapped up on that one?
That's my dementia.
I think there was one question. Did you still have a
Someone in the back
question?
there, yeah. The two questions in the back, yeah. Go ahead, in the back there, yeah.
Is it still safe for a patient to take drugs at the same time, like, Preventative and other, aspirin and aspirin? And then maybe which one is the drug of choice as far as, the blood thinner is concerned? Because too much has a lot of, proper.
Oh, so that's a good question. There's always a debate. So typically we put one antiplatelet therapy. I usually pick aspirin because it's the cheapest, and my patient population can't afford clopidogrel. But depending on other risk factors, if they've had gastric ulcers and stuff like that, then we pick clopidogrel and not aspirin. Now, in regards to dual antiplatelet therapy, we do have stroke patients who are on both. And the patients who have large vessel disease, meaning atherosclerosis from carotid disease or, the larger blood vessels in the brain, the actual studies and now the guidelines is that after stroke, they're on dual antiplatelet therapy for 90 days. Because when we were training, we were actually put a stent in there. But we've shown that putting the stent is actually not superior than medical management, but the medical management is dual antiplatelet therapy. So we do have patients who are on it. Usually they're on it only for 90 days and then they just go to one antiplatelet after that. So if you get a patient in your clinic or you have a family member, that's why they were sent with dual antiplatelet. Now there's newer antiplatelet medicines that some of the physicians use, like Brilinta or Pletal. Those are also, there's no studies to say one is better than the other. It's just the practice. I am old-fashioned. I don't try the new medicines. I take after my father's training. I use aspirin and Plavix. So, but if they have a stent, they may be put in Brilinta. Now, then we always get to the question of somebody has atrial fibrillation, they've been on Eliquis, and they've now had a stroke. So did they fail Eliquis? We typically, if they have cardiovascular disease on top of it, I typically start a baby aspirin. It's a little bit higher risk of bleeding, but that's what I would do. So I think this gentleman's had multiple.
Oh, go ahead.
Just one quick question. You mentioned vitamins is not the way to do it. But let's say your doctor's telling you you are low on, for example, vitamin D, right? And you say take 500,000 whatever from this one. And then, I do tell him exactly what I'm taking. And apart from that, there are other stuff that I take. And he doesn't seem to have any problem with it. So I'm basically following the doctor's advice. Is that the way you would think we should do? Right?
Yes.
Yes, of course. And I may have not been clear, there are benefits to vitamins, right? But my point is that we practice evidence-based medicine, which is based on evidence, and we don't have enough evidence about ashwagandha and some of these, like
Black cohosh.
red rice yeast. I mean, the ones that you never even heard about. Now, if you went in and you're presenting with, numbness and tingling, and your doctor says, Sir, you have vitamin B12 deficiency. You should go on vitamin B supplements. Absolutely go on vitamin B supplements. Your vitamin D is low. We don't get any sun. Take vitamin D. Your iron is low. Take iron supplements. That's a different case. This is I guess what the conversation was about was, some of these supplements, I can't even think of any name. Herbal supplements, there could be benefit. I'm not saying that, but we just don't have the proof. So what are the risks? I can't tell you. And if you choose to take it, you're taking it at your own risk. That's the point.
Dr. Malik, you want to say something?
If they don't damage the health, they certainly damage the pocket.
Oh yeah. Again, the most expensive urine.
This is a real problem in our community.
Yeah.
I think even general population, they're willing to go ahead and do a vitamin shop and spend $200 or $300, but do not want to spend $10 or $15 taking the real medication.
Very
Right.
true.
So
That's true.
the issue is there is no magic treatment. If there was a magic medicine that cured these illnesses, science is there. The pharmaceutical companies are around. They would have already incorporated that stuff in there.
Sure.
Think along those lines.
True.
They are not stupid. They are doing research 24 hours a day. And if any of the herbal stuff was really super treatment for these chronic diseases, would have already come through.